Hi guys, today I'll be discussing with you Prader-Willi syndrome. Meet the doctors behind this genetic disorder. Andrea Prader and Heinrich Willi first described this disorder back in 1956. They also worked with this guy, Alexis Labhart, who was an internist at the time. All three doctors actually saw the same patient, and his name was Albert. Albert was presented to Dr. Willi as an infant with severe hypotonia and obesity. He was later seen by Andrea Prader as as an adolescent, and then Alexis Labhart as a young adult. Prader was quoted stating in a national convention in 1984 that they began to realize that there was a group of children with identical symptoms and findings and a typical developmental pattern forming a syndrome which had not been described previously. Together, Andrea Prader and Heinrich Willi published works on the disorder, and it later became known as Prader-Willi syndrome. This disorder is usually diagnosed by a physician based on clinical symptoms. Diagnosis is then confirmed by a blood test. The testing used is called methylation analysis. This test detects more than 99% of cases of the disorder. A FISH test, or a fluorescent in situ hybridization test, can identify patients with Prader-Willi syndrome due to a deletion, but it will not identify those who have Prader-Willi syndrome by uniparental disomy or any imprinting errors. So what is Prader-Willi syndrome and how is it caused? Prader-Willi syndrome is a genetic disorder that affects not only physical attributes, but mental and emotional attributes too. The disorder is caused by a loss of function of genes on the 15th chromosome. As we have studied before, where's my mouse? I'm sorry. As we've just studied before, people usually inherit one copy of chromosomes from their father and then one copy from their mother. Some genes are turned on or active only on the copy that is inherited from a person's father. As you know, parent-specific gene activation is caused by something called genomic imprinting. Most cases of Prader-Willi syndrome, about 70%, occur within a segment of the paternal chromosome. I'm sorry, I keep losing my mouse. Here it is. The paternal chromosome. This occurs when a segment of the paternal chromosome 15 is deleted in each cell. People with this chromosomal change are missing certain critical genes in this region because the genes of the paternal copy have been deleted and the genes on the maternal copy are actually turned off. In about another 25 to 30% of the cases, a person with Prader-Willi syndrome has two copies of the chromosome 15 inherited from his or her mother as opposed to one from each of the parents. This is called maternal uniparental disomy. In even more rare cases, Prader-Willi syndrome can be caused by translocation or by mutation or other defect that abnormally turns off or inactivates the genes on the parental chromosome 15. I've added a cool little video that shows you kind of how the deletion works. It appears likely that the characteristic features of Prader-Willi syndrome result from the loss of function of several genes on chromosome 15. Studies have shown that the loss of a particular group of genes known as the SNORD116 cluster may play a major role in causing signs and symptoms of Prader-Willi syndrome. However, it is not known how this group of missing genes could contribute to intellectual disability, behavioral problems, and the physical features of the disorder. Oh, sorry. As I stated before, this syndrome usually presents itself in infancy with severe hypotonia, which is muscle weakness, poor growth, and delayed development. Beginning in childhood, affected individuals develop an insatiable appetite, which then leads to chronic overeating and obesity. Some people with Prader-Willi syndrome, particularly those that are obese, tend to develop type 2 diabetes. Let's see, where's my mouse? Other people with Prader-Willi syndrome typically have mild to moderate intellectual impairment and learning disabilities. Behavioral problems are common, including temper outbursts, stubbornness, compulsive behavior such as picking at the skin, and sleep abnormalities may occur. Additional features of this condition include distinctive facial features such as a narrow forehead, almond-shaped eyes, and a triangular mouth. Short stature and small hands and feet have also been noted. Some people with Prader-Willi syndrome have unusually fair skin and light-colored hair. Both affected males and affected females have underdeveloped genitals, and puberty is delayed or incomplete. Most affected individuals are unable to have children. Currently, there's no cure for Prader-Willi syndrome. However, lives of these individuals can be improved with early diagnosis and careful management of the symptoms. Treatment of Prader-Willi syndrome is based on treating the symptoms as they arise. Growth hormone deficiency is present in almost all children and many adults with Prader-Willi syndrome. Multiple studies have shown that the human growth hormone, HGH, has been found to be beneficial for those with Prader-Willi syndrome. As of June of 2000, HGH was officially approved by the FDA in the United States for use in patients with Prader-Willi syndrome. HGH is effective not only in increasing height, but also decreasing body fat, increasing muscle mass, improving weight distribution, increasing stamina, and increasing bone mineral density. In addition, studies have suggested its positive effects on development and behavior. Testosterone has been used to help with puberty as well. There's been a few case studies on this genetic disorder, and here I've included two for you guys to look at. This one is patient 1, is a 3-week-old female presented with hypotonia, inactivity, weak cry and suck, and dysmorphic features. She was then tested, and she did have the only one normal copy of chromosome 15, and it says that she had a derivative of chromosome 3 and the result of an unbalanced translocation between 3 and 15. Treatment. Upon her evaluation, she had not began any therapy. Echocardiogram was normal. Renal ultrasound revealed mild bilateral pilocollectasis. Sleep study found mild obstructive sleep apnea and other neurological problems. The outcome and ongoing management of her disorder. At 22 months of age, the growth hormone dose was 0.23 milligrams per week. Patient is now able to babble, roll over, and push herself up on her arms, but cannot crawl or sit unassisted, which is amazing recovery. Weight, height, and head circumference percentiles have increased satisfactorily. Her phenotype is more severe than most cases of Prader-Willi syndrome, but her profound global development delay is consistent with other cases of large atypical deletions or unbalanced translocations. Here we have a 5-year-old male in a wheelchair presented with the deletion of Prader-Willi syndrome, and he was diagnosed with methylation testing during newborn NICU stay. Looks like previous growth hormone treatment was stopped at age 3. BMI is greater than 99th percentile, and patient could no longer walk. He began seeking food and snoring or gasping during sleep, so that is like sleep apnea. He had began picking at his skin and having behavioral issues. Assessment and treatment. Patient had no scoliosis, but his age of his bones were actually the age of 10 at the age of 5. his HGH simulation was performed, and tonsillectomy, adenoidectomy, turbinate reduction, and direct laryngoscopy and bronchoscopy were performed. Neurology and cardiology assessments revealed no concern. Social work helped initiate in-home therapy and special needs preschool. Growth hormone therapy was restarted. And his outcome was the child began walking within 2 months of reinitiation of growth hormone. Growth hormone was discontinued after a sleep study revealed severe obstructive sleep apnea, but was restarted after verification that CPAP use was 100%. Families maintained a diet and reports that the child is rarely sneaking food. So this shows that the human growth hormone therapy actually did work in both of these cases. Moving on to my phylogenetic tree, which I worked so hard on. My disorder was rather difficult to perform a tree on because this deletion is not have a lot of study in other species, but I picked the genetic code SNRPN, which is expressed only from the paternally derived chromosome 15 in humans. When I ran the blast for the gene, I found many species of monkeys, as you can see here, but not much else outside of that. That may be because due to a lack of research in other species and its pathogenesis outside of the human species. They do say primates are our closest relatives, don't they? So it looks like here humans are actually right here, and then it goes down, and I've added images of all the species starting from the top going around to the bottom. And actually, if you look at some of the facial features of the human, you will actually see in some of these species of the monkey similarities, like the small upper lip, which was very, very interesting to me. So yeah, here's my phylogenetic tree that I worked so hard on. I hope you guys enjoyed my presentation, and I look forward to getting feedback from you guys. Thank you.